important hardware of PAS system, the XBT buccal tube and the MLF brackets. But I did not introduce the prescription of these brackets. So today, I'll make it up. The topic of today is physiological curve of SPEE and 4D prescription of brackets. I will introduce it in the following three parts. One, revisiting the curve of SPEE from an orthodontic perspective. Two, effects of leveling curve of SPEE on extraction space. And three, 3D straight wire or 4D pass. Let's look at the first one. Revisiting the curve of SPEE from an orthodontic perspective. Let me ask you a question. Does curve of SPEE on upper arch or on lower arch? What's your answer? On upper arch or on lower arch curve of SPEE? Upper or lower? Upper? Lower. Lower. Only two answers. What about others? Nowhere. Okay. It's interesting to see in China, the answer is on lower arch. I'm not quite sure about in Thailand. So in Thailand, both upper or lower? Or only upper, only lower? Lower. Yeah, I think most dentists know the curve of SPEE is on the lower. Well, let's see what Dr. SPEE said. Dr. SPEE published this paper in 1890. Originally in Old German, then was translated into modern German, then was translated to English. Then we can read it. He said, the upward concave occlusal curves exist in human and animals that own tubercular articulate belly. But he did not say is curve of SPEE on upper or on lower arch. Then let's see this one. He said in the beginning, the curve of masticatory surface of the mandible is sometimes not very clear and is much flatter than in upper jaw, where it is seldom missing. In such case, the varying pressure exerted on the teeth appears to gradually induce compensation of the curve differences. Now, if you take another look, where is the curve from? You see, mandible, not very clear. Upper, seldom missing. So in the beginning, the curve is on the upper arch, right? Upper, there's a curve, and lower, almost flat. Then he said the varying pressure caused the compensation. So the upper curve become less and lower curvature become larger to make the compensation. So it seems the curvature originates from upper arch, not the lower arch. You may say, does it matter? Well, for prosthodontists, it may be the same, because why prosthodontists use curve of SPEE? For the full denture arrangement, right? For that purpose, I think prosthodontists will use the normal occlusion as their study sample. But we are orthodontists. We deal with malocclusion. So the curve of SPEE on upper arch and on lower arch may not be the same, right? Let's look at are the curve of SPEE the same for different types of malocclusions. One of my students did this study many years ago. She collected 108 cases, finished during 2006 to 2008 from 6 orthodontic departments of renowned universities across China. There were 30 male and 78 female. Average age is 15.8. And the classification involved 36 cases of each class 1, class 2, and class 3. Most of cases treated with SPEE-WIRE appliance. And she measured the curve of SPEE of whole arch from incisor to the second molar, and curve of SPEE of posterior arch from canine to second molar. And this is the result. She found before treatment, class 2 has larger curvature than class 1 and class 3. After treatment, they are almost the same. Our treatment level all curvature to almost the same. If we check the literature, Fiedler says in patients with class 2 retrographic mandible, the continuous compensative growth of lower incisors, making it more likely for angle class 2 malocclusion to have a deeper curve of SPEE. That's in anterior segment, right? Because of deep overbite. But if we look at Dr. Su Hong's research, in class 2 malocclusion, the first upper molar is more retrocline relative to the palatal plane. The more retrocline the molar is, the greater the SPEE curve in the maxillary posterior segment. So we describe curve of SPEE on upper arch. Second part, the effects of leveling curve of SPEE on extraction case. This is a 12 years old female. Chief complaint is irregular teeth and lip protrusion. This is her Ceph and intraoral photo. You see crowding and the class 2 relationship. Occlusal view. For this kind of case, we usually extract patients for premolars. Since it's a crowding, protrusion, high angle case, we use TID, implant anchorage, to enhance the anchorage can chew. The first wire is a 014 tie wire, and we retracted canines with TAD, not with the first molar. After 2 months, you see we relieved anterior crowding. So we took a static cast and made a 3D digital model. If we compare the before treatment and after 2 months first stage treatment, compare the first molar angle, you will see it changed a little bit, right? If we do superimposition on the stable area that Dr. Chen found by an implant study, we published it in OCR in 2011. You will see the posterior teeth move forward a little bit, and anterior teeth move backward. Then why, even without orthodontic force on first molar move forward? Well, if we use straight arch wire, engage to the incisor brackets, the molar will get forward tipping moment. So we level the curve of SPEE in just 2 months with very thin light tie wire. So it's easy to level upper arch even with very thin light tie wire. Even we use TAD to retract canine. If we move up the leveled occlusal plane, you see the apparent curvature on upper arch. So they are not leveled at the beginning. They have apparent curve of SPEE on upper arch in the beginning. The superimposition, you can see all posterior teeth tipped forward. That means anchorage loss, right? Even we use TAD to retract canine, not with molar to retract canine. So let's look at the effects of leveling curve of SPEE on extraction space. This is a Class 2 Division 1 case. Now we know there's a curve on upper arch. If we level the curve, the length of upper arch will be increased, right? If we cut this to lengthened length and put them in the extraction space, you will see the extraction space reduced, right? You only have this left for retract anterior teeth. So after first stage treatment, you use light tie wire to level upper curve of SPEE, you lose anchorage already. If we do not level the curve of SPEE, like in past technique, we keep the posterior teeth in backward tipping angle. Then we can use this for anterior teeth retraction, right? So the philosophy of physiological anchorage control is maintaining the physiological curve of SPEE in the upper arch could not only take advantage of the physiological anchorage reservation of the upper molars, but also provide additional space for retraction of anterior teeth. The third one, should we use 3D street wire or 4D pass? Oh. Maybe don't use it. Okay, let's review how street wire brackets prescribe the slots. Dr. Andrews, who collected 120 plaster models with excellent teeth alignment and occlusion from the clinics of himself and his colleagues, and measured the mean value of each tooth position and angulation. He used this data to prescribe the first set of street wire bracket. Let's look at the representative of this sample. Dr. Andrews is in San Diego. So if he collected study casts in his clinic and his friend's clinic, so it represents Americans, right? Not Chinese, not Thailand, right? And he collected the ideal occlusion case. That implies good jaw relationship. We cannot imagine if it's a skeletal class 3, we can get ideal or optimal occlusion, right? Or skeletal class 2, we cannot get max optimal occlusion for skeletal jaw abnormal cases, right? The third one, age. Dr. Andrews did not describe the age in his paper, the 6 keys paper. So when he visited our university and gave lecture there, I asked him the age of his study cast, the 120 cases. He said it's an adult sample. So now we know the representative of this sample: Americans, good jaw relationship, and adult sample. Now, let's see if your patient are Americans. Well, Japanese measured their normal and designed opaque street wire appliance because they find their data is different from Americans. Chinese collected 2 normal, one from Sichuan, so they developed HX street wire brackets. One from Beijing, they developed Z2 prescription street wire brackets because all those data normals are not the same. Second, jaw relationship. We learn from Steiner analysis, if the sagittal-skeletal relationship is normal, the incisor inclination is normal. But if it's a skeletal class 2, upper teeth need to tip lingually and the lower incisor tip labially to compensate the big MB angle, right? And for class 3, it's opposite. Upper incisor need to tip labially and lower incisor tip lingually to compensate the skeletal abnormal relationship, right? Then what about molars? Dr. Su's study shows for class 2, upper molar tipped back. For class 3, upper molar tipped forward. And recently, we compared the compensation of molar and incisors. This is the result. Upper molar to palatal plane angle, the relationship with NB is this compared to the incisor, upper incisor to palatal plane angle. So which correlation is higher? Molar, right? This correlation coefficient is higher than the upper incisor to palatal plane. This is in sagittal jaw relationship. Then we check the vertical jaw relationship. Upper molar to palatal plane, the correlation coefficient is 0.284. And incisor to palatal plane, 0.089. With no statistical significant difference. And you check the MPPP, upper molar to palatal plane, 0.364. But upper incisor to palatal plane, 0.106. Much less than upper molar to palatal plane. So this study tell us that molar compensate to jaw relationship much more than incisor that Steiner analysis told us. So we should not neglect the molar compensation. Third one, H. Is the angulation of teeth fixed after they have erupted. We use American longitudinal craniofacial growth sample with metallic implants collected by Dr. Matthews. You can find that in AOF website. This is 8 years old. Those are metallic implants. Superimposed on those metallic implants, 10 years old, 12 years old, 14 years old, 15 years old. Now you see molar tipped forward, growth downward and forward. You may ask, what about other buccal teeth? The good news is this sample has a 45-degree oblique head film at each observation stage. So we can take a closer look at the buccal teeth. This is 8 years old, 10 years, superimposed on the metallic implants. 12 years, 13 years, 14 years, and 15 years. Now you see all posterior teeth tipped forward during growth, and anterior teeth tipped backward during growth. We measure each tooth changes during growth and published it in AJODO 2018. You will see that's the changes during 8 years to 16 years. Now we know the teeth change their angulations during growth and development. Then what angle should we use to describe street wire appliance? They are not fixed. So what stages data we should use to describe our street wire appliance? Well, Andrews chose the last stage. He chose adult sample. That means the final stage after growth, right? So I say it's a 3D normal value. This is the American longitudinal sample with the metallic implants. This is the occlusal plane, and this is the average angle of molar at 8 years old, 10 years old, 12 years old, and 16 years old. This sample only observed to 16 years, no 18 years. But we can anticipate the angle will be tipped more forward at 8 years old, right? Because we see upper molar tipped this way during growth. Okay, now supposing this is 18 years old molar angle. Dr. Andrews used this to prescribe the buccal tube, 0 degree. If we put this 0 degree buccal tube on adolescent molar and insert a street wire, engage to incisor bracket, then molar will get forward tipping moment to express the prescription we put in the slots, right? And the molar will still erupt during growth. So it will move forward and downward. Then you may see it move even more forward than natural growth if using street wire. Now we know upper molar grew downward and forward. Can we take advantage of this knowledge to preserve anchorage? I came up with this idea. Why not adding a tip-back tube to give molar a tip-back moment to prevent it from forward tipping during growth? And the molar will still erupt along its non-axis. So the molar may go this way, moving downward and backward. For non-extraction cases, it means we push molar backward. Then we can solve the mild crowding or mild protrusion case, right? And for extraction cases, it means anchorage preparation already, right? If you know Tweed technique. Tweed told us if you want to enhance posterior anchorage, you push posterior teeth back first. Then use backward tipping molar to retract the anterior teeth. But with our technique, you don't need to push molar back. You just give it a tip-back tipping moment, and it will change the molar forward tipping to backward this way. Now, how do we know if the 3D streetwise prescription with like headgear or TAD, the anchorage of this kind of technique compared to the new technique? We did a study on this, and we published in a European Journal of Orthodontics. That's also a randomized clinical trial to compare PASS versus MBT. In this group, if doctor think that patient need maximum anchorage control, you can use TAD. But in this group, no this kind of anchorage auxiliaries, just the PASS technique. The result is the anchorage loss has no statistical significant difference. So in PASS technique, we change the prescription of all teeth. For buccal teeth, in SPEE-WIRE, they use 0 degree. But in PASS, we use -degree. Why we use -degree? Because the posterior teeth are in backward position in growing patient. They are growth to the upright position, not start with upright position. If you use SPEE-WIRE, the posterior teeth will be tipped forward to upward position, to the 0 degree of adult normal. But in that case, you already lose anchorage, right? So I call 3D SPEE-WIRE appliance aging design. Because for young patient, you use adult normal. So you accelerate posterior teeth forward tipping. That's aging design, right? In PASS system, we give all posterior teeth backward tipping angle and align upper teeth on curve of SPEE, like this. So I call it 4D prescription. That's a reverse aging design, right? We try to prevent or reduce posterior teeth forward tipping growth. And if we align teeth on the curve, another advantage is we have more space to arrange posterior teeth. If we look at this as a triangle, which side is longer, this side or this side? This side, right? And we align teeth on the curve. The curve is even longer than this side, right? So we have more space for posterior teeth and save that space to attract the anterior teeth. We don't level posterior teeth. For anterior teeth prescription, we use Chinese normal. If you have Tainan normal, you can use that. Okay, Co-40 prescription appliance provide enough anchorage to treat bimaxillary protrusion case. This is a 12 years old female. Chief complaint is bimaxillary protrusion. Her AMB angle and PP angle is slightly larger than normal, but within normal range. But if we check the upper molar to palatal angle, it's more than average. If you can remember, I said for skeletal class 2, molar tip back. For high angle, molar tip back. Now we combined skeletal class 2 and high angle, make upper molar tip like this for the compensation. Although the MB angle and MPPP is still within normal range, but they are larger than average. The effects adds up to make upper molar tipped back like this. Another factor is she's 12 years old. So all these three factors make upper molar tipped back like this. Intraoral, mild crowding. So for this kind of patient, we used to extract 4 premolars. If we use 3D prescription buccal tube, 0 degree, engaging incisor brackets, molar will be tipped forward to lose anchorage, right? Then you noticed anchorage lost. You add headgear or TID to push molar back, right? But now you have a new method, 4D strategy to prevent anchorage loss. You can use XBT buccal tube, the -25 degree round tube to prevent molar forward tipping during growth. That's this is the first stage appliance. You have already done that yesterday. After aligning anterior teeth, we found the second premolars and second molar. That's the second stage treatment. We'll do it today. Then we retract anterior teeth to close the space. This is after treatment. We finished the case in 21 months. If we check the profile, we improve it quite a lot, right? We do superimposition. You will see upper molar keeps the original angle, no forward tipping. That saves about 2.47 millimeter, as I said yesterday, right, from our study, RCT study. no forward tipping 7 degree can save 2.47 millimeter anchorage. And we retract the incisor apparently. No arch, we retract the lower incisor. And the lower molar keeps the original angle. Then we do anterior cranial base superimposition because lower and upper incisor retracted and patient growth. You see the condyle growth. So you see the profile changed apparently. This is before and after treatment profile. Now, I give the conclusion. I summarize it in 3A. The first A is adolescent. Upper posterior teeth continuously tip forward as the mandible grows. 3D prescription brackets based on adults normal will accelerate forward tipping of anchor tooth or teeth. Second A, adult. Upper posterior teeth incline back to compensate skeletal class 2 or high angle cases. 3D prescription bracket based on normal skeletal pattern will accelerate the anchorage loss. The third A, advantage of 4D prescription. To strengthen anchorage in extraction orthodontic treatment, which significantly reduce the reliance on headgear or TAD for anchorage control. So if you learn how to use 4D technique, you can save a lot of case from using TAD or headgear. It makes the technique simple, right? And I think that's for most of your cases. In our orthodontic department, adolescents, about 70%. And adults, 30%. In adult patients, if class 2 is 1/3, then another 10%, that's 80% of patients, not appropriate to use straight wire blinds. If it's a high angle case, maybe another 5%. So maybe 85% of patients are not fit straight wire blinds, 3D normal. That's why I say 4D pass can simplify our technique, fix the blinds. Okay, that's the first lecture I want to share with you. Now, we do the second stage treatment. Before that, you need to move all the teeth from the first type down model to the second type down model. So you move all the teeth to the second type down model. Then you can align all the teeth immediately. After finishing this, you can take a rest, take a break, okay?
As malocclusion, in which the mandibular incisor crown are excessively overlapped vertically by the maxillary incisor when the teeth are in centric occlusion. Deep overbite may cause some unfavorable sequence, such as periodontal disease. In this case, we can see the bone loss and the gingival resection in lower incisor teeth. Also, it can cause TMD and abnormal function. It has been said that deeper overjet and deeper overbite are twins. Where there is a deeper overjet, there is a deeper overbite. It is very common in angle class 2 division 1 case. Okay, let's take a look at the development of the overbite when there is an overjet. There is a large overjet. The lower anterior teeth normally erupted until contact is made with the upper anterior teeth. If the molar relationship is class 2 and the lower incisor can erupt it until they contact the palate, this can cause the steep anterior curve of SPEE. This is why you got a large overjet, you got a large overbite. Sometimes the tongue can restrict the over-eruption of lower incisor in some class 2 cases. Sometimes deeper overbite can accompanied by normal overjet. This is such as in angle class 2 division 2 case. Then how to measure overbite? Deeper overbite is one of the index of ABODI, which is used to evaluate the severity of malocclusion. Overbite is a measurement between two antagonistic teeth, right or central incisor, and the reference is the lingual surface of the upper incisor. However, in PAR index, overbite is recorded in relationship to the coverage of lower incisor, and the reference is the labial surface of the lower incisor. The teeth with the greatest overlap is recorded. Deeper overbite collection. The collection of deeper overbite is one of the primary objectives of orthodontic treatment. Deeper overbite has been considered one of the most common malocclusion and the most difficult to treat successfully. Treatment of deeper overbite involves careful diagnosis, treatment plan, and mechanical plan. Before we discuss how to open the overbite, let's say something about the vertical facial taper. The vertical facial taper can be divided into high angle, average angle, and low angle according to the mandibular plane angle. So when MPSN plane is larger than 37 or MPPP plane angle larger than 32, it's high angle. If MPSN angle smaller than 27 or MPPP angle smaller than 23 angle, 3 degrees, then it's a low angle. Sometimes we don't need to do the measurement. We just look at the self and we can judge whether it's a high angle or low angle. The left one is high angle, yes. This is average and this is low angle. Let's discuss the treatment of deep overbite from diagnosis, treatment plan, and mechanical plan. Deep overbite can be classified to dental deep overbite or skeletal deep overbite. We know low angle case with deep overbite is a skeletal problem, and the treatment plan is to extrusion of the posterior teeth. Then we can use bite plate, tip back bands plus class 2 elastic, posterior vertical elastics. And to the average case, we can either extrude the posterior teeth or intrude the anterior teeth or both. Usually we can use bite opening curves. And to the high angle case, our treatment plan is to intrude the anterior teeth. When we intrude the anterior teeth, we should judge which anterior teeth to intrude, upper or lower. If we want to intrude upper anterior teeth, we can use utility arch, pickback arch, dry hook, or TED. If we want to intrude the lower anterior teeth, we can't use a dry hook. Let's see some case. So, in an average angle, we can usually use bite opening curve. These are two different type of bite opening curve. The left one is a individual archwire with bite opening curve, and the right one is a pre-made archwire with bite opening curve, whose molar width is small. In our clinical work, we use bite opening curve a lot. So this case just from the book. In the upper arch, we use the bite opening curve like a spiral curve, and the lower arch is a reverse spiral curve. Let's see the effect of bite opening curve. This is the pre-treatment, and this is our goal. Let's superimpose it. We can see the extrusion of the premolars, procline of the incisors, and the distal cline of the end molar. Case 2, we use the tip back bands and class 2 elastic in average to treat average angle case with deep overbite. This is a 13-year-old boy with retrusive mandible. For class 2 molar relationship, deep anterior overbite and normal overjet. So this is the typical angle class 2 division 2 case. We can see his upper second premolar will block out from the dental arch. From his pre-treatment self, we can see his skeletal class 2 and with the average mandibular plane angle. So here is the average case with deeper overbite. In this case, we use tip back band and class 2 elastic to extrude the posterior teeth. Do we really want to extrude molars in class 2 case? In adult patient, the extrusion of the molar can cause clockwise rotation of the lower jaw, result in more pronounced mandibular protrusion. However, the extrusion of the molar is accompanied by the growth of condyle, and the mandibular doesn't rotated clockwise, and the mandibular plane won't become larger in growing patient. So in this patient, we can extrude the posterior teeth. For second premolar were extracted in this case. Usually we will choose extract upper 4 and the lower 5. In this case, the upper 5 were blocked out. So we had the upper 5 extracted. Then we use tip back band in the lower arch made from Australian wire. This technique is from the bag technique. In bag technique, there are bite opening bands to activate arch wires so that they can depress the anterior teeth in order to open up anterior deep overbite. In conventional bag technique, the bite opening bands are given medial to the molar tuber, and the anterior segment of arch wire is made to a line gingival to the blanket of the lower incisor. Class 2 elastic were used to control the inclination of the upper incisor and to correct the molar relationship. Finally, a normal overbite and overjet were achieved. Also, we corrected the distal class 2 molar relationship. The boy got a nice smile and a good profile. Let's compare the pre-treatment and the post-treatment profile. We can see his mandible became normal because of the growth. This is the post-treatment self and the panel. In case 3, we will use a bite plate to correct a low angle deep overbite. In low angle case, the bite plan has several tapes. This one is a removable anterior bite plate. And this is a fixed bite plate modified from non-applies. Sometimes we use a fixed bite plate because the patient just don't want to wear the bite plate. This is bonded bite plate with composite resin on the palatal surface of maxillary incisor. And the bite ramp is used in Invisalign appliance, similar to the bite plate. This patient is a 24-year-old male. His anterior teeth were injured a few years ago, and we can see his upper right lateral incisor is enamel dentin fracture. His right middle incisor is enamel dentin pulp fracture, and the left middle incisor is a crown root fracture with pulp exposure. He wanted to restore his anterior teeth, upper anterior teeth, and his prosthetist told him that he needed an orthodontic treatment to open the deep overbite before restoration. This is pre-treatment self and panel, and he's a skeletal class 2, low angle case with deep overbite. And he has a traumatic anteriors, so which he is a really tough case. So for the low angle case, we wanted to extrusion the posterior teeth, and bite plate was used in this patient. So upper middle incisors are hopeless teeth and were extracted. Removable bite plane was used to open the deep overbite. Someone may ask, when is the time to remove the bite open bite? And the patient is really care about when he can drop the bite plane. It's not convenient for him. So my answer is when the lower arch is engaged with a hard stainless steel wire, which can maintain the bite opening effect of the bite plate. Usually it's 18 by 29-inch stainless steel wire. Finally, we close the extraction space, collect the deeper overbite of the front teeth, and establish a balanced occlusion. This is the post-treatment self and panel. You can see his anterior deep overbite was collected to normal, and the patient has enough room for restoration of his anterior teeth. Comparing the lateral self before and after treatment with SN as a reference, we found that the mandible plane angle didn't increase. So extruding molars is not so easy to achieve in lower angle case. Let's see another case. We use bite plate to collect high angle patient with deep overbite. It's an adolescent patient. This is a 13-year-old boy. This case is from our book, Physiological Anchorage Control. The boy has a retrusive mandible, deep overbite, class 2 molar relationship, high angle. This is the first book about physiological about pus and was published in 2016. So the first book about pus is in English. Our Chinese version will be published, I think, in this year. So he's a skeletal class 2, high angle. So we had 4 first molar extracted, and headgear was used at first to inhibit the growth of maxilla and the distal lines of the upper molar. Noting that the class 2 molar relationship had been corrected and the lower incisor clouding was relieved. After 9 months of headgear wearing, pus applies was bonded on the upper molar and anterior teeth. Thin nitrile wire were engaged in tip back tube to align the upper anterior teeth, and the anterior bite plane was used to open the bite. Then, lower anterior teeth were bonded 4 months later, when we could find that upper anterior teeth had been aligned. In the end, the stainless square wire was used to close the space and open the deeper over bite. Finally, we collected the deeper over bite of the anterior teeth and established an ideal occlusion. According to the tracing mandibular superimposition, we see a lot of growth in the condyle, and that's why we can use anterior bite plate in high angle case. The growth of the condyle is basically matched with the extrusion of the molar. So the mandible plane angle will not increase due to the extrusion of the molars. Case 5, we use a piggyback arch to collect a deep bite in high angle case. This is a 13-year-old girl. Her profile is good. Her chief blind is crooked teeth. From the intraoral photo, we can see her molar relationship is class 1. Modulator clouding in both upper and lower arch, and the anterior deep over bite. So this is a simple clouding case. She is skeletal class 1 and has a high angle. In this case, piggyback arch were used. The piggyback arch were made of Australian wire used in both arch. The upper piggyback arch is used for upper first molar upright, and the lower piggyback arch was used to intrude the lower incisor. The piggyback arch was inserted into the main tube of the XBT tube. In the lower jaw, we can see we use canine to canine segmental nitrile wire to align the lower teeth, lower anterior teeth. Usually we use the piggyback arch in the lower arch to open the deeper overbite, to include the lower incisors. For choosing the anterior teeth, the force should pass through the center of resistance so that translation takes place without any tipping. In the sagittal direction, the center of resistance of the anterior teeth locates between the central incisor and the canine. So flaring of the incisor occurs when the point of force is further away from the center of resistance. So if we want to include the anterior teeth bodily, the anterior part of the piggyback arch should tie here. And if we want to flare the anterior teeth, we can make the regulation here. So this is the post-treatment photos. We correct the anterior deep overbite. Post-treatment photos. Self and panel. Last case, we use TENS to treat high angle case with deep overbite in adult. This is a 33 years old woman referred by a prosthodontist whose chief complaint was teeth wear and gummy smile. Her pre-treatment facial photos show a good profile with a moderate gummy smile. From the intraoral photo, we can see she has a class 1 molar relationship and canine relationship and moderate overjet, about 4 millimeters. The overjet was so deep that clinical crown of the lower incisor couldn't be seen from the frontal view, even though the upper incisor was severely wound with the dentin exposure. Supplementary analysis showed a class 1 skeletal pattern with a steep, with a high angle. So in this high angle deep overbite case, our goal was to include the anterior teeth and maintain the mandible plane angle. We needed to judge which anterior teeth to include, upper or lower. We can include the upper incisor because the patient has a gummy smile. And in this case, we use TENS to include the upper and the lower anterior teeth. To include the upper incisors, 2 mini screws was placed between the upper lateral incisor and the middle incisor in order to avoid the tipping of the upper incisor during the intrusion. A class 2 elastic were used. When we finished the intrusion of upper arch, I was asked to include the lower incisor also. So the lower anterior teeth were also included by mini screw. Finally, we completely opened the deep bite of the front teeth and create enough room for the anterior teeth restoration. Let's compare the pre-treatment and post-treatment overbite. This is a really deep overbite, and we overcorrected it. We got an open bite when we finished the case. We measured we use the superimposition of the pre-treatment and post-treatment digital dental cast to measure how many millimeter we achieve. The maxillary incisor were included about 3.9 millimeters, and the mandibular were included about 4.2 millimeters. We can see the gingival margin of the lower anterior teeth were leveled. So when including the anterior teeth, it is very important to pay attention to the patient's sex and age. According to Nanda's study, the mean amount of teeth exposure in men is 1.9, while 3.4 in women. This means female has a larger teeth exposure in the maxilla. As the age increases, the exposure of the upper central incisor gradually decreases, while the exposure of the lower incisor gradually increases. So in an adult patient, don't include the upper incisor too much. Take-home message. So in most of cases, you can diagnose and treat anterior deep overbite based on this chart. In severe skeletal case, we may need orthognathic surgery. Thank you.
In this morning, I asked a student, are you bending wire in your daily work? And the girl said that to me, not so much. So I think maybe it's very interesting in past treating course. Yeah, I think you like it. I think you like it. I believe that these 2 days of course have made everyone get more understanding of past technique. Now, let's get an overall idea of the treatment procedure. Although treatment methods may differ for different malocclusions, but the basic treatment procedure can help you to follow past mechanics easily. Confucius had said that a man must sharpen his tools before he can do his work well. Let's review our past system, the physiologic anchorage SPEE-WIRE system. The unique design of PASS is believed to have the advantages in preventing molars forward tipping and physiologic anchorage loss. the first part, the cross buccal tube, named as XBT, consists of the minus 25 tip-back tube used to prevent the forward tipping moment caused by night-tie wire. And the other part, the minus 7-degree rectangular tube used to prevent molar anchorage loss when closing spaces. Like iPhone 6s says, the only difference is that everything is different. That's said about the XBT tube. And the important part of the multi-level low friction bracket, named as the MLF brackets, in the early treatment can lower ligating friction, and in the late treatment can enhance tooth control. Like an architect always says, less is more. Here and here, we can have many control. With these weapons, we can move the tooth backward easily, just like the word, give me a fulcrum. I can move the earth. Okay, let's take the type-down model to view the PASS procedure. PASS technique can be divided into 3 basic treatment stages. Each has its own objective. Let's take a class 2 extraction treatment as an example to illustrate it. The absolute distal molar relationships with 4 first premolars extracted, as you get in your hand. And from the crucial view, the four were extracted. And we get the PASS appliance, the buccal tubes, the MLF brackets, and the super glues. The water bath, we don't have it. So we have 2 type-down models. Now we can see there are 3 stages. And now we will see the stage 1, alignment. The objectives of stage 1 are to relieve crowding and correct rotation, to prevent forward tipping of molar or upright forward tipped molar, to start to open deep bite, and to start to correct midline. First, the first step, we have aligned the anterior teeth by using the round tube of XBT. Everyone, we know the first step, we make the buccal tube and the 3-2-3 brackets bounded on the upper teeth and the lower teeth to relieve crowding and correct rotation, and to align the anterior teeth. When the arch wire is inserted in the tip-back tube, and from the upper arch and the lower arch, we can see the night-tie wire, or thin night-tie wire, is inserted in the tip-back tube, and in the lower, inserted in the tip-back slot or the hole. We use it to insert the hole. At first, we always use a thin 14 night-tie wire engaged in the minus 25-degree round tube on upper molar and the minus 20-degree, we call it virtual tube, a virtual tube, or we just call the tip-back slot on lower molar. When engaging the night-tie wire in the minus 25-degree upper XBT and minus 20-degree lower XBT tubes, dominant moment will be put on anchor molars for most cases, And this will also protect molar from forward drifting in a lining stage. We can see the frontal and lateral view after we bound the brackets and the buccal tubes. The bonding position for the MLF brackets is just like a conventional straight wire appliance. That's a closer view after bonding. On the type down, we bound upper and lower 3-3 MLF brackets. The XBT on the first molars. Bonding position of MLF is just like the straight wire appliance, but bonding XBT on first molar is a little bit tricky. Orthodontists used to orient the main tube direction parallel to occlusal rim of molar, which will make the minus 7 degree main tube as a 0 degree tube, just like conventional buccal tubes. The correct way to orient it is to make the occlusal edge parallel to the buccal tube line. This parallel to the buccal tube line. The red line represents the occlusal edge of the base of XBT, and the yellow line is the minus 25 degree, and the blue line is minus 7 degree relative to the red line. The orientation of the XBT on first molar make the occlusal edge of the base here parallel to the molar cusps, and the visual enhanced at the 1 second crown height. This line, the base parallel to the molar cusps. When engaging the 14 night wire in the 25 degree upper XBT and the 25 degree lower XBT tubes, dominant moment will be put on anchor molars. Here. And this will also protect the molar from forward drifting. We can see the closal view. Here we can see the cinch back in the lower arch and the lower cinch back in virtual tubes. We can see the cinch back in main tubes in the lower. Everybody, you have a cinch back plier? It's very useful when we use the pass technique in pass system. We always get a cinch back plier, just a clip is okay. We can adjust friction by selecting different ligatures and ligating methods. For example, selecting a 20 or 25 or 30 ligature wire based on severity of rotation of anterior teeth. The single wing ligation can be used on rotated teeth and overhanging ligating on severely irregular tooth. We can see a single wing. Here is a single wing. And sometimes we use overhanging ligating. You can see it, a single wing and an overhanging ligating. There's a video. Yeah. For canines, we advise you to select a 20 ligature on distal wing to lower friction on it so that it can drift back more easily and gradually change to the thicker ligature when anterior crowding is relieved. There are many different ligating methods. You can do what you want to do. Okay, you can see a case. That's the frontal view 2 months after bonding. You can see we bonded the 3 to 3 and the 6. And the ash wire inserted into the tip-back tube and tip-back slot. The left side you can see the crucial view 2 months after bonding. You can see the tip-back, the cinch back 2 months after bonding. You can see, okay, aligned well. In the lining state, there are many typical characteristics with, you've seen this. With 20 ligature wire sliding to the top of the wings, the MLF brackets appear like self-ligating brackets. We can see it clearly here. The ligature slide on top of the wings. So the first stage aligned fast. And you can see here, this lower the system friction, and under the 6-3 moment or the 6-4 moment, at this case, the anterior teeth moves back and space appears spontaneously. Even we use ceramic brackets. The anterior tooth moves back and space appears. The second step, if we faced a deep overbite or forward-tipped molar cases, or cases who need to reinforce anchorage, a piggyback arch, you've bent it, the piggyback arch is used to tie on anterior segment. When we use it, that piggyback arch, we use in the cases with deep overbite, with forward-tipped molar, we need to reinforce anchorage. We use a piggyback arch. Not for all the cases. Yeah, you've bent it. We often use 20 stainless round arch wire, or to the 1725 or 1825 stainless steel rectangular arch wire for the piggyback arch. You've tried it. First you bend a Z type. Then we add angle on the Z type. The angle, I often made it about 30 degrees in the first time. When we use we use 18 stainless round arch wire. We can adjust the backward tipping angle as we need, and as the patient needs. We can watch it if it goes well in the patient's in the patient's mouth. To prevent flaring of the anterior teeth, ligating on distal wing of lateral incisor or medial wing of the canine, plus cinch back ligating on first molar will help. Mostly, we won't cinch back here. We can bend it just okay, just near the measure of the buccal tube. For the purpose of correction of deep overbite, the intrusion auxiliary arch could be ligated on different positions, such as the laterals, or the canines, or the central incisors, as we need to open the bite. Two-tip molar bag ligating on canine wings, combining with a class 2 elastics can be used. If we don't want to open the bite, we just want to tip back the molars, we can tie the piggyback arch on the canine, and then we can move the molar tipping backward. You can see there are a piggyback arch in the lower. Piggyback arch to tip molar back or intrude anterior teeth. Errors showed cinchback ligating and ligating on distal wings of lateral incisor or medial wings on the canine. For this one, tie the laterals. And we can use a SS round wire in the upper and the piggyback arch in the lower, and use the class 2 elastics. It's very, very useful for the open bite cases and space closure. And class 2 elastics on canine to facilitate upper molar backward tipping by piggyback arch. We can see the case 3 months after bonding. We use 2 piggyback arches on the lower and the upper. You can see the picture. And the piggyback arch were tied on the laterals. You can see the left side. 3 months after bonding, we use a piggyback arch. Here. In this open bite stage, the unique double wing system become the typical characteristics of past system. If we need a piggyback arch, then there's a double wire view. When we finish stage 1, the main arch wires are often the 16 night wires, and the finishing statement are the first molars are slightly backward tipped, and the anterior teeth are well aligned. Then, back to our procedures. Let's start with stage 2, restore physiologic or compensated curve of SPEE. Here. The objectives of stage 2 is to complete correcting rotation and midline deviation, to establish the upper curve of SPEE and the stable posterior anchorage unit, to reduce the incisor proclination, to level irregularity in the third order direction, and to level the lower arch and finish deep bite correction. Then we bond upper 7 and upper 5 brackets and tubes. Their little cheek, we should gingivally a little bit on the 5 and occlusally on the 7 in order to restore upper curve of SPEE. Here, a little bit gingivally on the 5 and occlusally on the 7, so we can restore the curve of SPEE. In past technique, individualized curve of SPEE can be realized by manually adjusting the curve size on arch wire. There are 3 factors that determine the last formation of upper posterior curve of SPEE. One, the pre-adjust backward tipping angles on posterior brackets or the tubes. Two, the vertical positioning of brackets or tubes. And three, the curve size on the arch wire. Okay, we can see we found the 5 and the 7 in order to restore upper curve of SPEE, the closal view. Then we change to 16 or 18 night-high wire, night-high round wire with normal curve of SPEE into the main tube, the rectangular tube in upper arch. And we change 16 to 18 night-high wire with reverse curve of SPEE into the main tube in lower arch for deep overbite cases. There's a normal curve of SPEE, just a little angle, not a very big angle. So we can see the main tube with normal curve of SPEE in upper arch and reverse curve of SPEE in lower arch, just reverse it to maintain opening bite. And there's two choices next. The step 3, we choose upper arch wire. After alignment with the 18 night-high wire, we can choose the next wire according to the procline angle of the anterior teeth. If the upper incisor is proclined apparently, we can use 18 SS round arch wire with the helical loop and normal curve of SPEE. Then we continue midline correction with unilateral tie back and use intra or intermaxillary elastics to correct anterior teeth inclination until they are uprighted to normal inclination. Then we change to an 1825 night-high arch wire with normal curve of SPEE. If the upper incisor inclination is almost normal, we directly use the 1825 night-high arch wire with normal curve of SPEE to level irregularities in third order direction. Yeah, you've banded it. The 18 SS round wire with a helical loop here. It can be used for the patients with proclined incisor. And it can retract the anterior teeth very fast. We can see 18 SS round arch wire and can slightly close space and use the class 2 elastics if we need. In the mouth, we can see we can use it for the retraction of proclined incisors. And step 4, finish establishment of the curve of SPEE. For upper arch, when the upper anterior teeth are uprighted to normal inclination, then we can change an 1825 night-high arch wire with normal curve of SPEE. For lower arch, after correction of rotation, we can change the 1825 night-high wire, make a reverse curve of SPEE in deep overbite cases, and combine class 2 elastics. Then we finish stage 2. And the main arch wire always been the 1825 arch wire, night-high arch wire with normal curve of SPEE. The case, bond 5 and 7, use a main arch wire in the main tube, the closal view. In this stage, all the teeth are bonded. All the arch wires are used with normal curve of SPEE. We open the bite to normal and get teeth ready in third order for engaging the stainless rectangular arch wire. Then, let's go to the stage 3, space closure and refinement. So in this stage, it's easy. We establish good occlusion according to skeletal jaw relationship. In the upper, we can use 1825 SS with physiologic or compensated curve of SPEE plus traction hooks. The student asked us, where is the hook on the canine? We use a hook here. We use a hook on the arch wire. We do an MS retraction. Yeah. In the lower, we use the 1825 SS with slight reverse curve of SPEE plus traction hooks. The power chain to close space or a tie back is okay, and intermaxillary elastics to adjust occlusion. So the main arch wire we used was the 1825 SS rectangular arch wire, not 1925, just 1825. We can use the power chain to close space and intermaxillary elastics to adjust occlusion. The front view, the lateral view, another side, occlusal view. The finished statement of stage 3, the upper arch shows physiologic curve of SPEE. Here, you can see it, the occlusal view. And the typical characteristics here are different slot height front to back and the distal tipped posterior teeth with bite. And also, it's fast. So, back to our past procedures, let's get a review. The treatment is very simple, right? No other auxiliaries. First, we bound upper and lower 3-3 brackets and the XBTs on the 6th. We can engage a 14 night high, or we can choose a 12 or to the 16 night high. In the tip-back tube, or in the minus 25 in the upper or 20 in the lower tip-back tube, then we cinch back. We can bend the piggyback arches if we need. And we finish stage 1, we can see a slightly distal tipped molars, well-aligned anterior teeth. In this stage, we can use auxiliary techniques. We can use different ligating methods and cinch back plier methods and piggyback arch methods. Then we finish stage 1. Then the stage 2. For upper arch, we bound 7 and 5. Then we change to 16 or 18 night high with normal curve of SPEE in the main tube. This stage we always in the main tube. Or if upper incisor is proclined, apparently we use an 18 SS round arch wire with loop and normal curve of SPEE. When the upper anterior teeth are uprighted to normal inclination, then we change to 1825 night high arch wire with normal curve of SPEE. For the lower, we bound 7 and bound the 5. After correction of rotation, we change to the 1825 night high, make a reverse curve of SPEE in deep overbite cases and combine class 2 elastics. Here, we finish stage 2. Then we go to stage 3. We use the 1825 SS with physiology curve of SPEE plus traction hooks, lower 1825 night high upper SS wire with slight reverse curve of SPEE plus traction hooks. We use power chain or tie back to close space and intermaxillary elastics to adjust occlusion. Then we finish our treatment. We can see in the mouse. First, we band 6 and 3-3. Use a thin night high wire. For the patient, we want to enhance the anchorage. We use a piggyback arch. Yeah. Then we bound 5 and 7. Then, because this patient had proclined incisor, we use 18 SS round arch wire with a loop to retract the anterior teeth. Then we use intermaxillary elastics to adjust occlusion. Then we finish the patient with a normal curve of SPEE. Another patient, the same procedure. Okay. Okay, at last, let's look at a video and also give an overall idea of the treatment flow. You can see it. Okay. The disadvantage of straight wire appliance in anchorage control. Anterior crowding, as an example, we extract 4 and the brackets and a 0-degree buccal tube. A thin night-high round wire inserted into the buccal tube, and the anterior segment closely. When the arch wire engaged into the incisor brackets, first molar forward tipping, and incisor extruded. How canine position affects molar anchorage. When the arch wire is inserted, okay, you can see here the canines. Okay, first molar will receive a forward tipping, same as the canine. Yeah, and canine will go down, and the molar will tip forward. As a result, both of them will tip forward. The advantage of pass in the early stage of alignment, we bound the XBT, the round tube with a minus 25 degree, and the night-high wire is a gingivally. In the anterior segment, then the molar is under backward tipping moment. And we can see a 6-3 relationship here. The canine is different under clockwise moment, both in the molar and in the canine. Clockwise moment will make them backward. In the lower arch, we use a piggyback hole. Oh, that's the main tube. Yeah. That's the piggyback tube. The anterior overbite control and posterior anchorage preparation. When align the anterior teeth, we can use a piggyback arch. The purpose of using the piggyback arch is to upright molar a little bit, prepare anchorage to intrude the anterior teeth. Then we establish the normal curve of SPEE in upper arch. We bound 7 and 5, and 7 closely and 5 a little bit gingivally. Then we use a round arch wire with curve of SPEE to line the upper teeth. Gradually transit to 1825 night-high wire. Establish curve of SPEE. Then we close the extraction space. Use a 1825 SS arch wire with normal curve of SPEE. Use a power chain or tie back. Close the space. Okay. Yeah. Then cases with PASS techniques and understand the advantages of PASS in treating each different kind of malocclusions. I will give you 10 cases. Okay, first, let's talk about crowding cases. Yeah, there are two common causes of crowding. The dental-skeletal discrepancy or abnormal displacements of the decidus and permanent teeth. From the pictures, we can know the dental-skeletal discrepancy means relatively less bone and relatively more teeth. The treatment plans are more likely to extract teeth. And deciduous tooth retention and early loss of deciduous molars could lead to the forward tipping and shifting of permanent molars and coarse anterior crowding. Since upper canine is the last one to erupt in the dentition before first molar, it's often dislocated severely due to the lack of spaces like that, such as these patients. All of them have high canines. The tiger canine, I showed this yesterday. These canines could bring many troubles when come to our orthodontic treatment. In the first premolar extraction case, the initial 9-tie arch wire will tip posterior teeth forward and take more spaces and change the functional occlusal plane when aligning the high canine. Here. In the upper first molar and the second premolar are prone to be tipped forward in lining stage if no anchorage control measure is applied on posterior teeth, especially when they are in backward tipping position. Either due to the growth stage or compensation of skeletal jaw relationship, which may change the FOP. When we change conventional buccal tube into XBT tube, the force system reversed, and the molar tends to gain anchorage. If using the minus 25-degree tip-back tube, molar gets tip-back moment, while the canine gets tip-back moment too. The figure shows canines in high position. Okay. When we use the 0-degree buccal tube, both teeth will get tip forward moment, as in Burstone class 1 or class 2. The molar tends to lose anchorage, and if we use the minus 25-degree tip-back tube, the molar gets tip-back moment, while the canine gets tip forward moment as Burstone class 5 or class 6. The molar tends to gain anchorage. The figure shows the canine is in forward tipping angulation. When using the 0-degree buccal tube, the larger wire slot angle is on canine, so the canine dominates the system moment, and the molar gets 1/2 of the canine moment with the same direction. If we use the minus 25 tip-back tube, both teeth will get tip-back moment, and the molar gets larger moment than the figure A. And the low friction mechanism of PASS system not only reduce the force to retract anterior teeth, but also lower the reaction acting on anchor molar, so that the dominant moment on molar may resist it well instead of using heavy force for the anchorage auxiliaries. Like this picture, I showed it once. In the lining stage, there are many typical characteristics with the 20 ligature sliding to the top of the wings. The MLF brackets appear like self-ligating brackets. And this would lower the system friction. Anterior tooth moves back and space appears spontaneously. Yeah, this boy again with severely crowded teeth. And he has a little weak chin, which means skeletal class 2. This is a boy with severely crowded teeth, and the canines are in high position. A straight night-tie wire initial aligning stage would cause the forward tipping of molars, and early anchorage loss. The blue line in this figure represents the buccal tube plane, which is coincident with the pretreatment FOP. And the black line shows the engaged direction of the initial straight night-tie wire into the canine and into the molar and the conventional molar buccal tube. The posterior occlusal plane will end up between somewhere, according to the mechanics, which will reduce the FOP angle and increase the protrusion of the upper arch. However, these are the ultra-oral photos of the boy 3 months after we used the PASS appliance. When a straight night-tie wire is engaged in such a thin tip-back round tube, the dominant moment will be on the anchor molar, which will usually result in co-rotating moment on the canine. And this moment will tip the canine backward to relieve anterior crowding without using any laceback or tats or elastics, so that there will be no anchorage load on the first molar, which is crucial to maintain the FOP, the functional occlusal plane. These are his digital maxillary model. Then we superimposed them. It can be seen obviously 3 months after bonding. The severe crowding was relieved, and anterior molar didn't move forward, and anterior teeth didn't incline labially. And can be seen similarly with the lower teeth. After 2 months aligning, the severe crowding was relieved, anchor molar didn't move forward, and anterior teeth didn't incline labially. And we could measure the 3-dimensional changes of each tooth. The first molar almost stays still. You can see the molar almost stays still, while the right canine tipped backward by almost 20 degrees and moved backward by almost 9 millimeters. Whoa, just in 3 months. Similar phenomenon happened in the lower and in the left side. The PASS technique provides a novel and simplified way to align anterior crowding without stressing on the anchor molar. The magic PASS aligned the severe crowded cases in 3 months without anchorage loss or proclined anterior teeth. I think it's so unbelievable. How long would be the conventional straight wire appliance to this? I think it would cost 1 year, maybe. Okay. Case 2. Here shows a 16-year-old girl Okay, they're the same, the crowding cases. Yeah. And the girls class 1 with severe crowding and anterior crossbite and neutral relationship and upper crowding, lower crowding severe. A mild skeletal class 3, angle class 1, skeletal class 3, and we extracted her 4 premolars and used PASS technique. And the duration was 1.5 years. Nearly 1 year, she over his treatment. The first stage PASS to put night-high wires were used. After 3 months, canine drift back spontaneously on the low friction MLF brackets without elastic force or lace back. Anterior crowding was relieved, and the canines were aligned on the arch form, and some spaces between the anterior teeth appeared. Then we bound 5 and 7 and restore the anchorage and close space. Within 1.5 years, the girl finished her treatment and she had got a beautiful smile. Yeah, the teeth were well aligned, the molar and canine relationship were standard class 1, intercuspid occlusion was greatly improved. Here's the cephalometric films. The comparison of before and after treatment shows great improvement, and the girl got a beautiful smile and was very happy. The comparison of the frontal view greatly improved in the lateral view, and the physiologic curve of SPEE was maintained. And here's cephalometric tracings before and after treatment. A superimposition. We can see a maximum molar anchorage and the lip retraction. Okay, and the table shows the cephalometric analysis of the case before and after treatment, and the FOP angle increased by 1.7 degrees, which reversed the forward tipping tendency of the FOP in normal growth pattern. And instead of accelerating it as in conventional SPEE-WIRE system, then we go to the protrusion cases. We know that the bimaxillary protrusion is characterized by proclined anterior teeth, protrusive lips, a convex lower facial profile. The strategy of the orthodontic correction of this type of malocclusion should involve retraction of anterior teeth and with maximum anchorage. Typically, after extraction of the 4 first premolars, thus correcting dental alveolar discrepancy. For these patients, the alveolar bones are always fully developed with or without skeletal protrusion, long dental arches with fully erupted teeth, and all the teeth tip forward without severe crowding. The advantages of PASS treating bimaxillary protrusion involve the XBT tube to prevent molar forward tipping after premolar extraction. The second advantage, the MLF brackets can facilitate anterior teeth drift back along the arch wire when they get tip back moments. You can see here. Yeah, we can see the drift space. And the conventional SPEE-WIRE system always change the FOP counterclockwise rotating, while the backward tipping angles in all posterior brackets and buccal tubes of PASS system also inhibited the forward tipping trend. Here is the conventional SPEE-WIRE system. So the third advantage of the path for the protrusion cases are the backward tipping angles in all posterior brackets. Can maintain posterior curve of SPEE that saves more spaces for anterior teeth retraction, as well as the arch wire with normal curve of SPEE can save more space and can produce more space when we use a curve of arch wire with curve of SPEE than the straight wire. And the fourth advantage is the 20 inches incisor slots. The incisor torque control is strengthened even with a 1825 SS retraction arch. So the 1825 arch in 22 slots in posterior brackets or tubes also reduce the third order friction in space closing stage. So there are so many advantages for the path system to correct the protrusion cases. Let's see a girl with protrusion. 13 years ago, and she had the scissor spine, moderate crowding, and the diagnosis was angle class 2, skeletal class 2, and we extract for first premolars use path technique, and the duration was nearly 1 year. Here's the pre-treatment films. We can see a protrusion. The 1 month after bonding view, I used the 14-19 XPT tube and block the 6 up with the GIC, and I start to treat the scissor spine with mutual elastics to make the 7 upright. And after space closure, I was adjusting the occlusion then. Just 1 year with the girl. So beautiful. The teeth were well aligned, and the molar and canine relationship were standard class 1, and the intercuspid occlusion was greatly improved. And we can see a beautiful cephalometric view. The parallel, the roots were parallel. Comparison of the frontal view of occlusion shows great improvement, and she had a relaxed, happy smile and good occlusion. We can see the normal curve of SPEE, physiologic curve. Here, in the left side, you can see the physiologic curve of SPEE was maintained well. And the second molars were well uprighted. The teeth were well aligned, and the molar and canine relationship were standard class 1, and intercuspid occlusion was greatly improved. The comparison of before and after treatment shows a beautiful smile, a relaxed and happy profile. Here, a superimposition shows maximum molar anchorage and lip retraction, obvious retraction of the upper and lower incisors, and improved profiles. After 4 years, she came to our hospital for follow-up. The even teeth were well retained, and the intercuspation were well retained. Case 4. She's not very confident, maybe a little self-abased. A 24-year-old girl who sought orthodontic treatment because of the severe protrusion, lip incompetence, and proclined anterior teeth. You can see abnormal tapered lateral, moderate crowding, and the diagnosis is angle class 2, skeletal class 2, and we extract 4, and the duration is 1 year and 3 months. Yeah, very protrusive profile. And first, we use a 14-9-tie wire in the XBT tip-back tube to align anterior teeth. 3 months after bonding, the anterior teeth were well aligned. Then we use 18 SS piggyback arch to open bite and prepare anchorage to tip back the 6. And the anterior bite opened well. And we found that there was no posterior anchorage loss. 7 months after bonding, we used the 18 SS round wire to close space and to improve the protrusion. Next, we changed to the 1825 SS rectangular arch wire to close space and adjust the occlusion. Only 1 year and 3 months, we got a beautiful girl. We finished all the treatment of this severe protrusive adult patient with PASS system. We can see the teeth were well aligned and the molar canine relationship was standard class 1. And the intercuspid occlusion was greatly improved because of a tapered lateral, maybe a little deviate midline. That's okay. We can see the physiologic curve of SPEE. Yeah, got a improvement in the profile. Comparison of the frontal view. Both the occlusion and appearance of the teeth were greatly improved just 1 year and 3 months here. The comparison of before and after treatment shows great improved, and we can see the protrusive profile improved without any tests or any other auxiliaries. And we can see a simple and fast treatment, and the gummy smile improved, and we can see the relaxed lip, mild chin. Just 1 year and 3 months. Use the PASS. The molar were tipped back. The molar tipped back obviously, and we got a good anchorage control. And the 5th case, another protrusion case, a 24-year-old girl, protrusion, lip incompetence. We can see severe proclined lips and lip incompetence and tense metalis. And in the lateral, we can see protrusive maxilla and lip incompetence. The intraoral view showed that all the third molars were well erupted and the teeth before them showed more forward tipping. There were local anterior open bite, and she couldn't bite well. Remember the characteristics of bimaxillary protrusion? Alveolar bone are fully developed with or without skeletal protrusion, and the long dental arches with fully erupted teeth. All the teeth tip forward without severe crowding. Yeah. All of them imply the treatment of PASS system. Okay, the diagnosis was angle class 1, skeletal class 2. And we extracted the 4 fourths and the 4 third molars. We used PASS technique, and nearly 1/2 and a year we finished the treatment. After rebonding, the moment after we bonded the girl, we used the 14 9-tie wire in the tip-back tube, the tip-back hole. 3 months after, I use a piggyback arch tied on the canine to tip back the molar to reinforce the anchorage. She didn't need to open bite, but I think I want to reinforce the anchorage, so I used the piggyback arch. Then I tied it here. We can see the 3 months moment. The moment after bonding and the moment in 3 months, we can see the canine is tipped back, yeah, here. And the anterior crowding relieved, and the open bite reduced, and the molar relationship maintained. I used the piggyback arch to tip upper first molars back to reinforce the anchorage. Then after 20 months treatment, the girl changed another girl, and the teeth were well aligned, and the protrusion were corrected. We can see the post-treatment cephalometric fumes. Before and after treatment, we can see the comparison. The profile improved, yeah. I think she's happy. She's angry, maybe. We can see a soft lip and mild metallus. Comparison of frontal view of occlusion. And we can see the upright 7, 6, 5, and upright the canine. We can see the comparison. Upright the upright incisors. You can see that the upper molars were tipped backward to prepare anchorage, so that the anterior teeth were retracted more. Yes. Here are the changes. The soft tissue changed well. The hard tissues improved well. And we can see a huge retraction. Here, the table shows her cephalometric analysis before and after treatment, and her incisor protrusion and the label inclination were largely reduced. And the FOP angle here increased by 2.4 degrees, and the MP angle were almost maintained. Case 6, crossbite. We've showed this case, so we just keep a fast snap. Okay, we did a compensative orthodont treatment with no extraction, just to correct the crossbite. We can see we use the arch wire. We insert them in the main tube with no extraction case. And 2 months after bonding, the boy can feel the lower incisors could touch the upper incisors. 3 months after bonding, the anterior crossbite corrected. Yeah, the main tube, the wire were inserted in the main tube in the non-extraction cases. After 8 months, we used the 1825 SS rectangular arch wire to adjust the occlusion. 1 year's treatment. We changed a boy, and the teeth were well aligned, molar and canine class 1. The intercuspid occlusion was greatly improved. We can see a proclined upper incisors because of the compensative treatment of PAS. And we can see the curve of SPEE. The curve of SPEE will correct the forward tipping molars. A beautiful profile. The crossbite improved, smile line improved, concave profile improved. Within 1 year's treatment bypass, we can see a beautiful chin. A neutral molar and canine relationships, crossbite correct. Yeah. We can see the curve of SPEE here. You can see the change between before and the after treatment. Okay. There's the changes before and after treatment in the cephalometric films, and we can see the soft and hard tissues superimposition. Then we add the soft tissue changes. Only 3 months treatment with PASS, I think we changed the boy's life. So, I want to see, some may think that PASS is more useful for the class 1, class 2 cases, but there are many advantages for the PASS to treat the class 3 cases. I think let's see the advantages. Advantage 1, the tip-back upper molar can provide space for anterior alignment, can provide extra anchorage for class 3 elastics, and can reduce the horizontal force transmitted to upper anterior section, which is good for the maintenance of the AP position of upper anterior teeth and profile. When we tip back the lower molar, can provide enough anchorage for the maximum retraction of lower incisors. And when we use the low friction of MLF brackets, can make the best use of lower lip muscle to assist lower anterior teeth retraction and the correction of anterior crossbite. So there are also many advantages for the PASS system to correct the class 3 cases. This is another adult with a protrusive mandible, and his class 3, skeletal class 3, protrusive mandible and protrusive lower lip. Intraoral examination showed class 3 molar relationship, anterior crossbite, crowning and 90-degree rotated lower second premolars, and the cephalometric analysis revealed it was a skeletal class 3 cases with protrusive profile. Orthodontic camouflage treatment using PASS technique was applied with the aim to moderate anchorage to relieve crowding and establish class 1, and in the lower to maximum anchorage to retract lower anterior teeth. And the upper 5 and the lower 4 were extracted. Through lower 5 were about 90-degree rotated. They were retained in considering of a maximum anterior teeth retraction. And then the lower 8 were also extracted before treatment to release posterior crowding and provide space for possible the whole lower dentition distalization. After relief the lower crowding, we can start class 3 elastics by taking advantage of the XBT's double tube design. One with thin night tie to line anterior teeth. You can use a double wire. And 8 months later, the upper dentition was initially aligned, anterior teeth were edge to edge, and the power chain was used in the lower arch to close the scattered space, and the GIC were gradually grinded to allow closer adjustment of the posterior teeth. And 12 months later, the normal anterior overbite and overjet were established. Then the second molar were bounded and aligned. 16 months later, the former cases of 1925 SS arch wire were with normal curve of SPEE were placed in both arches for the final space closure. Then adjust occlusion. And the good treatment result was achieved in 24 months. Besides well-aligned dentition and good occlusion, the facial profile was improved by retracting the lower anterior teeth. We can see the profile was improved well. We can see the neutral molar and canine relationship, the crossbite corrected, very good overbite overjet and coordinate midline, and maximum intercuspation. From the comparison, we can see crossbite improved, smile line improved, and protrusive profile improved, soft lips before and after the treatment. A superimposition of pre and post shows maximum molar anchorage control and significant lower incisor retraction. And let's come to the class 2 correction. I think there are many advantages of PASS in treatment of class 2 malocclusion. And the strategy of class 2 treatment with PASS, we focus on upper dentition control by preventing upper first molars from forward tipping. And we want to maintain the upper posterior curve of SPEE to reduce or even reverse the forward rotation of upper posterior closal plane and facilitate class 2 correction, which are accomplished by design of the XBT tube and other necks. And the low friction of MLF bracket and the reinforced torque control of the anterior teeth and blah, blah, blah. There are many advantages for the PASS to treat class 2 cases. Let's see, Professor Tianmin's case. A 13-year-old girl, and the chief complaint was stuck out front teeth and 2 full lips. The deep overjet, we can see diagnosis is angle class 2, skeletal class 2. And we extracted 3/4 and 1/5 use PASS technique. We can see class 2 profile. Initially, only anterior teeth and the 6 were bounded, and we used the T-back tube to prevent mesial drift of the upper molars. And when the anterior teeth were aligned, the upper 7 and upper 5 were bounded and used a 18 night-high wire with normal curve of SPEE to line the anterior posterior, upper posterior teeth and maintain curve of SPEE. 6 months later, you can see double wire system. Yeah, to give the apparently proclined upper front teeth. In the upper, we use the 18 SS round wire with the helical loop and the normal curve of SPEE to retract and upright the anterior teeth. And in the lower, we use the piggyback arch to open the bite, and we use a class 2 elastics to correct anterior teeth inclinations. We can do many things in one follow-up. And 9 months, the midline discrepancy and excessive overjet had been corrected. And we use a 1825 night-high wire with reverse curve of SPEE in the lower, combining class 2 elastics to correct the deep overbite in the lower arch. And 14 months later, when the upper curve of SPEE and the stable posterior anchorage unit were fully established, we used sliding mechanics using an 1825 SS rectangular wire to close the residue space, and still we use a class 2 elastics to create the molar relationship. Then the girl finished her treatment about 20 months later. Yeah, the teeth were well aligned and the tight interdigitation was set up and compensate curve of SPEE was maintained. You can see upright 7, 6, 5, 3, and we can see the normal curve of SPEE. Very beautiful profile. After treatment, the smile line improved, the protrusive profile improved, and soft lips and chins. We can see a maximum anchorage control before and after treatment. The case was published on the APOS Trends in Orthodontics and Experts Corner, new concept of physiologic anchorage control. Okay, let's go to another type of malocclusion, a periodontitis with malocclusion. When treat orthodontic cases with periodontitis, are there many periodontic patients in Thailand? Yeah. We all know that patients with periodontitis are a little bit trouble. When treating them, besides the oral hygiene instruction and controlling, there are some key points. I think the stress is increasing with the alveolar bone loss, especially when the loss beyond the cervical 1/3 of the root, which remains while retracting maxillary anterior teeth. Typically, it's the life force to need. We need low friction, we need light force, we need less pressure, we need less bodily movement, we need more tipping movement. So, all of them means the PASS technique is very suitable for the cases with periodontitis. You can see this case, it's very, very dangerous. But with the PASS, we can treat it like that. Here's a 31-year-old girl who sought orthodontic treatment because of the severe crowding, protrusion, gingival recession, and periodontitis. She's not very confident. Intraoral photos before treatment show class 2 relationship and severe crowding. Here, severe crowding and multiple gingival recession. We can see he had a really steep lower SPEE curve when caused severe occlusal problems. Here. The cephalometric radiograph shows a mild skeletal class 2 jaw relationship and a high mandibular jaw. And the panoramic radiograph shows severe bone loss in multiple areas, especially the anterior area. So the patient was extracted 2 upper first premolar and 1 lower incisor, bonded with the XBT on the 6th and the 3-3 brackets in the upper, and we bound all the teeth in the lower. We use 20 ligature wire and a 12-90 wire is lower. The friction was lower on anterior teeth so that can drift to relieve crowding. 4 months after binding, we can see the canine tipped back without less back or elective force, and anterior crowding was relieved after 4 months treatment, just like the driftodontics along the archwire. And the lower, we can see there are no space here in 4 months aligning, and the overbite were gradually relieved. After 6 months, we can see the lower curve changed better here without any auxiliaries. The treatment progressed by using a 1825 night-high wire in upper dentition and in the lower with reverse curve of SPEE. And 11 months later, the bite ramps were used to level the steep lower curve, and it was changed well here. The steep curve was changed well. The space closure stage was proceeded with a 1825 SS wires with normal curve of SPEE. And 20 months after bonding, she finished her, she under fine occlusal adjustment. Okay, about 25 months later, the girl finished her treatment, and we can see the self-abased girl changed to another person, a very beautiful woman. Yeah. About 21 months later, a good treatment result was achieved, besides well-aligned dentition and good occlusion. I think it's good, because we extracted one incisor. I think this is good. So the post-treatment cephalometric films and panoramic films, we can see the bone loss is okay and maintained before the treatment. And we can see the smile line improved and protrusive profile improved, and we can see the soft lips. Another girl with periodontitis. The last case, periodontitis and protrusion. We can see the gaps. We can see the gaps between the teeth, and the chief complaint is gaps and protrusion. In the front view, you can see severe proclined lips and lip incompetence and tense metalis, or the protrusion characteristics. We can see acute nasolabial angle and protrusive lips. There are many bone loss. Maybe in the middle of the root. The intraoral view showed that all the third molars were well erupted, and the teeth before them showed inclined, forward tipping. Yeah. Then we extract the 4/4, use PASS technique. The duration is 1.5 years, 2 months after bonding. We bond 5 and 7. And 1.5 years, the teeth were well aligned, the spaces were closed, and the intracuspid occlusion was greatly improved. 1.5 years, we used PASS technique, changed another girl, a beautiful girl. I think the PASS made her younger. And we can see from the post-treatment films the excellent parallel roots here and no more alveolar bone loss before in treatment comparison. We can see the maximum intercuspation, the smile line improved, yes, profile improved, soft chin. In the comparison of the panoramic view, we can see excellent parallel roots and no more alveolar bone loss. comparison of several metric films, she changed a lot. We can see the upright first molar very comparatively. Maximum anchorage control. Here comes the discussions with PASS, what we can do with PASS, how the high efficiency treatment. Okay, here, I showed them before. Compared with conventional SPEE-WIRE system, the PASS aim to maintain the posterior speech curve to respect the physiologic rules and occlusal functions and the characteristics. We keep the natural anchorage restoration to avoid artificial molar forward tipping, and then we reduce anchorage loss, then we reduce space loss, then we strengthen the anchorage. So that's the first PASS advantage. For another advantage, when we use a SPEE-WIRE system, the molar would be tipped forward, and we use, in these cases, and when we use PASS system, the molar maintained and the canine shifted backward spontaneously. The innovative tip-back tube can provide a unique canine molar differential moment, the 3-6 differential moment, and the dislocate canine and molar simultaneously under backward movement. Then the canine drifts backward quickly, and the molar doesn't tip forward, and then the anchorage strengthened. I think the canine, the corner of the dentition drift backward quickly is very, very crucial key for the high efficient. So that's a very crucial key advantage of the PASS system. And the third advantage is the MLF brackets. At least 10 kinds of combinations of lectures and arch wires can let us control the most appropriate value of friction and orthodontic force. Then we can drift the teeth freely under control. So we reduce the system friction. We can use the rapid backward movement of the anterior teeth in the initial stage, and we can get accurate control of the anterior teeth in the later stage, low friction sliding on the lateral side. So I think posterior stable molars, anterior easy control, and the rapid low friction sliding is the 3 crucial advantages of PASS system for you, for all the orthodontics. We can keep the functional occlusal plane and make a better occlusion. So PASS equals effect. We also almost depend on no more other auxiliary attachments such as mini screws, headgears, lens arches. So PASS equals simple. We can avoid unnecessary forward-backward movement and reduce the duration of treatment. So PASS equals efficiency. The last but not the least, we respect the physiologic boundaries. So PASS equals health. Let's go back in the front slide. After this lecture, we know that with PASS, it's very easy to do the orthodontic work like that. Oh. When Apple company carries out the face recognition on mobile phones and makes innovative progress, it is named the iPhone X, saying hello to the future. Yeah. When Tesla electric car makes innovative progress, it is named Model X. Yeah. When space rocket technique makes innovative progress, it is named SpaceX. And later, I found that as early as 2010, Professor Xu named the XBT. X stands for the future. So, if you want to embrace the future, embrace the XBT. So pass as soon as possible. So welcome to dig more wonderful theories and brilliant cases in this book. I think you can book it on Amazon or any internet. We can book this book, or you can ask the Yao in Xinya company. Thank you.